This is the area to be treated. As you can see, there is 2 recessions at the level of the 2 central incisors of the lower jaw. Unfortunately, you can see that there is some recession also of the interproximal papilla, which will make this cement enamel junction a bit exposed, and so the predictability to cover completely this recession is highly reduced. But again, we will try to make fun of biology, as I will show you later, as we did yesterday, by extending the desepithelialization of this papilla a bit more lingually, and so being able to advance the flap in the surgical papilla of the flap a bit more lingually, and making the connective tissue graft at the level of the cement enamel junction of the 2 teeth. As you can see, there is almost no remaining keratinized tissue. This is not keratinized tissue, you see it's alveolar mucosa that is probable, and the amount of keratinized tissue remaining at the level of these tooth, it's almost nothing. So in this situation, it's absolutely mandatory to use a connective tissue graft. There is no way for using the matrix, because we need to improve the stability of our flap at the time of the surgery. The anesthesia has to be done far away with respect to the surgical area. The needle is bent towards the interincisors area. I start a very slow injection. In the lower incisors is even more important that the injection is very slow, because we don't want to create any trauma to the alveolar mucosa of the lip. That is the alveolar mucosa that we will use for verticalizing our flap. You see the frenulum, you see how short, almost nothing, is the vestibulum depth. I will show you a bit better before starting the surgery in the profile of this patient. But you can appreciate when you make anesthesia that the muscles, the submucosal tissue, becomes completely perpendicular to the root surface, making 0 the depth of the vestibulum. That obviously has to be restored surgically if we want to perform the coronary advanced flap. So once upon a time, the coronary advanced flap was completely contraindicated in this area, because of the lack of vestibulum depth, because of the lack of keratinized tissue, and only the 2-stage procedure, which is the procedure in which a free gingival graft is placed first, and then a connected coronary advanced flap was done 3 months later, was the main indication. Today we learn how to advance the flap, how to verticalize the flap also in the lower incisors, and so we can do everything in one stage, even if obviously this is a procedure that it's a bit more complex with respect to that one that we have seen to be applied in the upper jaw. Very slow injection. You see the swelling, despite I'm really injecting extremely slowly. You see the swelling in the surgical area, and this is because the complete absence of keratinized tissue. Now you do on the end vestibulum depth. Now you do the same on the other side, close, very apical, outside of the surgical area. We don't want to make any perforation in the pedicle. In this time, in this surgery, in this area, it is mandatory to perform the anesthesia in the palate first, because in this area we have no time to lose. It's a surgery that is very complex, the tissue is extremely thin, and your surgery shouldn't last more than 1 hour and 15 minutes, 1 hour and 30 minutes maximum, and so you have to save as much as time as possible everywhere. And obviously during the time it takes for the spread of the liquid in the lower incisors, I will take this time to perform the anesthesia in the palate. That is done exactly in the same way I showed you before, so I don't show you now, because in this way I don't have to change the position of the camera, but I will show you during the harvesting procedure. Now we have to wait for the anesthesia to spread in the lower incisors, and in the meantime, in terms of vestibulum depth, is the distance between the lip that is completely horizontal and the soft tissue margin. So if you look at the position of the lip, where the lip and the muscles is inserting perpendicular to the root and the soft tissue margin, you can see that the vestibulum depth is really zero in this patient. So we don't have any vestibulum depth. The only area where there is vestibulum depth is here, which is from here and here, because here there is no resection, and we have about 4 to 5 millimeters, 4 millimeters of vestibulum depth. Here, nothing. If we advance the flap, here we place the muscles coronally, so we have to create a flap that will be verticalized, and this is something that we will see a bit better, I hope at least, at the end of the surgery. We don't have to make the same thing we did in the upper jaw, that is recession plus one, starting from the tip, because this makes the incision very, very apical. And the more you make the incision apical, the less is the amount of keratinized tissue you can keep in your papilla. So what I'm doing in the lower incisors is to keep the incision where there is the best quality of keratinized tissue, interdentally. So I'm looking where is the keratinized tissue from here to here, and I will make the incision where I can find the best quality of keratinized tissue. Here and also here. The area where there is good amount of keratinized tissue is not good. The best area is this. And the most difficult of all is here, because here there is alveolar mucosa. So I want to shift the keratinized tissue as much as the incision, as much as cornal, in order to take some keratinized tissue as much as possible in my surgical papilla. So first difference, the incision line must be placed where you have the best quality of keratinized tissue. Then the true vertical release incision should be very limited in apical direction at the beginning. We don't want to get the alveolar mucosa at the beginning, because I want to see much better. I want to see very, very well where to increase the length of the vertical release incision, to bevel this incision, until the whole papilla is elevated with the right thickness, right shape. Very, very difficult papilla. And once the most coronal aspect of the papilla can be elevated, I finish my split thickness elevation of the papilla, keeping the blade parallel to the bone until the imaginary line connecting the gingival recession to the vertical release incision is reached. So this is the first surgical papilla. This is the second one. Papilla. It's a bit easier because there is shallow recession with respect to this one. And now the most difficult of all, bevel, rotation, bevel, rotation. Now the whole papilla from one to the second recession is elevated. Quick. Now we have 1, 2 and 3. In the upper jaw it was easy because we have vestibulum depth to make full thickness elevation of the flap, while in the lower incisors it's almost impossible because the lip is completely horizontal. So what we have to do is one very complex incision, keeping the papilla far away, intracircular here, vai, togli il sangue, intracircular here, intracircular here, so I'm keeping the blade parallel to the bone, vai, until I don't reach here, the buccal bone crest. Here the buccal bone crest is reached. Now I have to check here. This is the deepest recession. You see here the tissue is attached to the root. Look. Now I'm detaching them. Parallel to the bone. Now I reach the most apical extension, right, of the bone. So the deep incision in the lower incisors, it's much deeper than the upper jaw because it's now necessary to increase the vertical dimension of the vertical release incision in order to get my alveolar mucosa free from the lip that is completely horizontal. So for the first time I increased the length of the vertical release incision in alveolar mucosa make this incision very superficial. One side. Same thing on the other side. Increase the vertical release incision. Make this incision very superficial. Now you should see very well the muscles inserting perpendicular to the root. The flap is only made by 1, 2, 3 papilla. Now I have to create a flap by making this superficial incision. So I pull the lip, make the incision very superficial. I pull the papilla here, vieni qui. I make this incision parallel to the lip. Now the most difficult area is the area of the frenulum, between the two papilla. Vai a respirare. Here. And you will gain this flap by removing the whole muscles in your flap, only using the tip but going with your flap parallel to the lining mucosa of the lip. And your safe area, it's only the area of the papilla, right? I pull the lip, remove the muscles, check the movement of the flap from inside. Now the flap is made of 3 papilla but also 2 vertical release incisions. And this alveolar mucosa, despite the presence of many scars here, You see, this is the scar. You see, this is scars. This is scars you create whenever you remove frenulum from outside. Scar alveolar mucosa. This is only scar, and you don't have to make any frenulectomy because you are creating scar, and this tissue is not elastic as it was before. Now that the flap is ready, you see that the muscles are still there. So what I have to do is to get 5 millimeters of periosteum apical to the root exposure, free from these muscles. So to get this periosteum, free from the muscles and being able to attach the flap to this area of periosteum that is just free. This area of muscles that was previously attached to the periosteum is physically removed by connecting the most superficial aspect of your superficial incision, sono qua, to the deepest aspect of the deep incision, so the whole area of 5 millimeters of periosteum apical to the root exposure is completely free. Now you should see that there is no muscles on this area of periosteum, and if there is, this must be physically removed. So now we have a very nice vascular bed, completely free from muscles for the whole lateral and apical aspect. We place a gauze. This is the only time that there is a minimum amount of bleeding. So we take a gauze, we protect the flap and start to make root planing. And the root has to be planed until, again, you start to feel good quality of the root. The most apical extension of the root should be safe from root planing if it was not probable. In this root we have probing pocket depth together with gingival recession, so we get very close to the bone crest. You can see here, there is also a minimum amount of buccal bone loss in buccal lingual dimension, which is quite frequent in the presence of such a buccally displaced root. You see here, this is the bone is quite good. Here there is some minor bone loss. Now we make root planing on the second root. Until the root is good. It sounds good. Okay, now I check again the noise. This is the area with the small amount of bone loss. So I want to remove the whole connective tissue, so to have also some bone regeneration in the infrabony component of the defect, where the graft is working as a barrier to prevent the soft tissue to collapse in this area. Okay, now it's time for ADTA application. Everything should be done very, very standardized, as I told you, because as you have seen and as you will see later, the dimension of this flap is really very, very small and extremely, 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 extremely thin. Now we are preparing ourselves for the desepithelialization of the papilla. So now we start with the desepithelialization, just the base with the blade, and 90% is done with the microsurgical scissors, because this is extremely small papilla, and almost all the desepithelialization of this papilla is done with the scissors, because this is done mainly horizontally towards the lingual aspect. As much as you are able to extend the desepithelialization. Now I keep the fingers in the lingual aspect in order to complete this desepithelialization on the occlusal surface. Siete? So to increase the blood supply towards the lingual aspect at the level of the interincisor papilla that was lost in height, and so we have to increase the the occlusal aspect for the desepithelialization. You see, I provide about 3 millimeters of connective tissue bed horizontally together with the vertical component of this papilla, and this is thanks to the extension of the desepithelialization towards the lingual aspect. Okay, now it's time for measuring the graft from the mesial to the distal recession. We have about 12-13 millimeters, while the apical column dimension of the graft, and this is another difference, is in relation to the vestibulum depth of the adjacent teeth, not 4 millimeters, only area where it is not 4 millimeters, but depends on the vestibulum depth of the adjacent teeth, which is 5. So we will take, how long? 13 for 5. Now it's time for the application of amelogenins. So during the time it takes for me to take the graft, this amelogenins can work. So I apply the gel now on the root under a very, very good control of the bleeding. Okay, now it's time to go to the palate. Okay, the incision the closest I can to the teeth. Always avoid the area of the rugae. I check the dimension. 13, vero?
Sì.
So it should be longer than this. I make the vertical release incision 5 millimeters long, and then I measure again in order to be sure that I have 13 millimeters before making the second one. Same rules of before: bevel, thickness, calibration of the graft by rotating the graft at the level of the mesial angle. Bevel, rotation, same thickness. Bevel, rotation, same thickness. Rotation means parallel to the soft tissue. Bevel, rotation, same thickness. Bevel, rotation, same thickness. Bevel, rotation, same thickness. Now it's time to open the distal vertical incision, rotating the blade, so also the distal vertical incision is open like the mesial, distal, mesial and middle. Now it's time to keep the blade parallel to the soft tissue, until the imaginary line connecting the soft tissue, the most apical extension of both vertical incision is reached, keeping the blade parallel to the soft tissue, increase a bit the depth of the vertical incision, also distal, so it's not bleeding at all during the harvesting procedure. Now everything is free. It's time to connect the most distal with the most mesial aspect. Make this incision deeper. Leave the old fatty and glandular tissue as much as possible in the palate and remove the graft. Now don't close it immediately, don't lose time. Ask your assistant to keep the gauze in protection because it's not bleeding at all. What do you see yellow? It's stem cells. So I keep these stem cells and I will use it for something that is more useful than a connective tissue graft. So I keep it, how do you say, congelato? Frozen, and maybe a new Zucchelli will born. So, but I will not use these stem cells for my graft. I will use the connective tissue. Now, blade oblique. Desepithelialization. Desepithelialization, and there is still an area here. Right. You need some saline in order to improve the cutting properties of your blade, especially when you reach the peripheral area. Now half of the graft is desepithelialized, you turn it, you place your blade on the already desepithelialized area. Here there's still an area. You should see quite well the difference between connective tissue and epithelium. So you get into the area where there is already desepithelialization, and then you make the desepithelialization of the second half. Don't forget that in the most corner area you bevel your incision, and so there is an area with epithelium and no connective tissue, and this is the area that I'm really facing just now. So first of all, I want to complete the horizontal desepithelialization, so to leave this area to be desepithelialized vertically with the vertical desepithelialization. Now I want to check also inside if there is some area of epithelium, and you can see that there is epithelium here all along. It means that when I did the apical incision connecting the two vertical incisions, it was not exactly perpendicular. I beveled also this incision, and so this area of epithelium must also be removed. So now we have good quality of connective tissue everywhere. Inside and outside is exactly the same story, good properties in quality in adapting to the underlying surface. I will check that there is no connective tissue, there is no epithelium along the vertical incision also, where sometimes we risk to bevel. Also this incision, and this is more frequent when you go posterior, where the blade cannot be exactly perpendicular. Okay, now I'm ready for my graft. Now also in the way that the assistant have to keep your lip, you shouldn't pull too much because you have a good control of the bleeding and you want to stimulate bleeding anymore coming from the pedicle. Now it's the time for the connective tissue graft application. This should be placed so that there is a very, very good adaptation also to the area of the defect, bony defect, because in this area this connective tissue graft is working as a barrier to prevent the flap to collapse, and so we will improve the levels, the buccal lingual dimension, the buccal lingual level of the bone also. If the graft is a bit thicker in the peripheral area, you can also reduce it a bit. Now we take the same suture material we have used before, the 7 millimeter long needle. And you see that the apical corner dimension of the graft is equal to the vestibulum depth. Every single surgical knot should be placed on the graft in order to be compressive and not at the level of the papilla. Bye. The graft should be placed at the level of the cement enamel junction of the teeth, leaving the papilla, especially the horizontally desepithelialized portion, completely free for the surgical papilla of the coronally advanced flap. Never suture the papilla that is weaker first. Now the last one, because this papilla has to be sutured in different way because it's like the papilla around the implants. I don't know if you remember, full thickness from the graft to the lingual aspect, getting lingually with a needle. Take the needle lingually. You have some problem in take it from the buccal to the lingual, but this is a full thickness perforation of the papilla. Then with an horizontal matrix I perforate the papilla from the lingual aspect and get out at the base of the desepithelialized anatomic papilla with the needle. You see here, I get out here. So when I'm closing now the surgical knot, there shouldn't be any graft on the papilla, but at the same time the graft is well suture to the base of the desepithelialized anatomical one. But at the same time, this horizontally desepithelialized papilla is completely free for the surgical papilla. Via. Of the coronally advanced flap. The way we sutured our graft, and it should be important to show you the adaptation of the graft at the level of the cement enamel junction, at the level of the root of the two teeth. Even if I'm trying to force the coverage of these teeth because there is loss of attachment, loss of bone, so theoretically it's not completely coverable. Okay, now there is another exception, very different from the upper jaw. In the upper jaw, remember, I don't like this suture. It's from the first time I made this suture, I was not happy, and when you are not happy, you have to do it again. This surgery, it's really very, very precise surgery. Don't leave anything to heal, so it was not well adapted in this area. 7. I was not happy about the positioning of the graft in this area, and so I want to do it again. It should be really stretched. Now I like it. Now there is the most important difference between the upper and the lower incisor. We cannot take the papilla in the final position with the pincet like I did in the upper jaw to close the vertical easy incision first, but I have to place the papilla in the final position and then close the vertical easy incision once the papilla is in the final position, and then after closing the vertical easy incision, I will close again the papilla, because in this time there is still tension, but as you can see, the 3 papilla are in the final position. So I will make the same sling suture I will do at the hand, surgical papilla, perforation, anatomical papilla, I will take anchorage to the distal papilla because I don't want to make perforation of the weakest papilla, that is that one in the middle. And this is called positioning suture. It's a suture that will allow me to position the papilla in the final position so that I will be able to close the vertical easy incision. So take anchorage to this papilla, going back, and now close the surgical knot, so to place the papilla in the final position without pulling it. It's only a positioning suture, so I want to check that this suture is in the middle. I don't like it at all. I don't like it at all. I don't like it at all. It should be placed in the middle. I made a trapezoidal shaped papilla because I want to have this papilla in the middle easier. So now the suture is in the middle. Now I do the same thing on the distal papilla. Surgical, anatomical, lingual aspect. Take anchorage distal to the distal papilla that was not elevated, but this allows me to position the papilla in the final position. Questo non è nuovo comunque. Voi mi prendete per il culo. Ah, il 6 non c'è, giusto?
C'è soltanto il
6.
6.
Sì? Now I go back to the starting point below the contact area, and again I will close this second papilla, trying to make this compression in the middle, but without pulling it too much. It's just a positioning of the papilla in the final position that will be done again once the vertical easy incision is closed. And you can see that the interincisor papilla is in the final position. So now it's time to attach my flap. It's vertical to the only tissue to which I can attach my flap, and this tissue is the periosteum. So I just suture also the interincisor papilla in the final position, and then this suture will be removed. So surgical lingual aspect, take anchorage in the one of the two papilla, selecting the biggest one to place the papilla in the final position. Si ho visto. I want to have the papilla in the final position before closing the vertical release incision. Otherwise, you are too much traumatic and it's almost impossible to achieve the verticality of the vestibulum. Now I displace this papilla more palatally. So that the papilla now is in the final position. And it's time to see the verticality of the vestibulum depth and to anchor the flap to the periosteum. We always start at the level of the smallest recession where the vestibulum depth is easier to be replaced. It's very important here to pull the lip but without but leaving the flap vertical, sort of pena pena. Most apical extension, vertical release incision, take the periosteum, alveolar mucosa adjacent. This is a periosteal anchorage suture in the area where the muscles were removed. And now when I close this suture, you see that the verticality of the vestibulum depth is completely restored. You see the flap is vertical, it's attached to the periosteum. Lascia un po' tu. Lì. Now I close this, and during this closure I have the vertical release incision perfectly in position, so that I can continue the closure of the vertical release incision with the 7-0 suture. This is the only 6-0, that one for the deep apical periosteal anchorage. Now I can close the remaining vertical component of the vertical release incision by connecting my flap, the adjacent attached gingiva with the 7-0 sutures, using periosteal anchorage and the adjacent attached gingiva to achieve a very, very precise adaptation of the flap to the adjacent soft tissue. The more you are precise in the closure of the vertical release incision, the better is the verticality you are replacing qui.
Il prof di... così? Ok.
Aspetta un attimo. All this suture has a periosteal anchorage in the area where the muscles has been physically removed, and so this flap can be attached to the verticality of the periosteum. Dai, tira un po'. Now that we are closer to the teeth, you see here, we can see very, very well the verticality of the vestibulum depth and the possibility to close, tieni così, your flap to the adjacent soft tissue. This is why you have to see, because theoretically I should not pull the lip at all. Now the flap, adjacent attached gingiva, you see, when you get closer to the adjacent tooth, you change the inclination, and from the flap to the adjacent soft tissue, respecting the area of the soft tissue margin and the probable area so that this is closed completely under any tension, because the papilla is already in the final position. Lascia pure un secondo. Now the last one along the vertical releasing incision, so to achieve the best closure. Very, very, very precise suture without pulling. You know, if you use a monofilament for this suture, it's very risky because this flap is extremely, extremely thin. Now we have to do the same thing on the distal vertical releasing incision. You see the verticality of the flap is already replaced. The papilla is in position. I have to do exactly the same thing at the level of the second vertical releasing incision. Now most apical extension, flap, periosteum, alveolar mucosa of the adjacent teeth. This is the deepest one, it's the most important of all. Theoretically, this shouldn't be pulled at all, because with this suture, you see, when I close this, I fix the surgical knot in position. Also, the distal aspect of the vestibulum depth is completely restored. Now we complete the closure like we did on the other side along the vertical releasing incision, and theoretically you should remove the blood in excess. You should not pull more than this of the vertical releasing incision. No, va bene così. Va bene, va bene. So we fix here to the periosteum, to the adjacent soft tissue. No, no, non si vede. Basta. All surgical knot must be displaced along the vertical releasing incision where you want to block your flap, not at the level of the adjacent tissue. Lascia pure. Dai. Now I will improve the apical closure to the periosteum. In this area, flap, periosteum, adjacent soft tissue, microphysiological. Basta. Surgical knot in position. Right. Now we can go coronal, and as much as we go coronal, the assistant should reduce the tension, so you should only see here at the level of the papilla area here. And now the last one, that is the oblique in the opposite direction to connect the surgical papilla to the adjacent attached gingiva, and this is done from coronal to apical direction in this way to join this tissue without getting to the soft tissue margin, only with this and the closure of the vertical releasing incision. Okay, now it's not finished, even if it should be finished theoretically, because you don't have to forget that the vertical release incision were closed where there was still a lot of tension. You see how the flap is completely vertical, and will be even better when I'm going to show you the profile of the patient. But now we have to close definitively the papilla, and the previous suture has to be removed because they was done where there was still tension. But you don't have to remove the suture first. You have to give the suture again so that you can remove the others once the papilla is in the position. So I will start with this suture. More apical than the others, in the middle, surgical, anatomical, lingual aspect, right? This is the sling, which is the definitive one. I place the anchorage to the different area, so I recognize the first with respect to the second one. And now, before closing this, I will remove the surgical knot. From the previous one, the papilla stays there. The previous suture can be removed. I will remove it later, the remaining part of the suture, and then once the papilla is already in the final position, I try to do it better than before, but now with no tension. That's the physiological. I don't have to see anymore. Right. Clean it. You don't have to see any sign. You see now it's well positioned. And now this can be pulled in the middle, but with no more tension because the vertical release incision is completely closed. And now I can finalize the removal of the first sutures, and now we do the same on the second one. In order to avoid to position again, surgical papilla in the middle, surgical, anatomical, lingual aspect. Take anchorage distal. Remember that we did the other one a bit more mesial, because if I cut the same, I will be a bit angry for this. Going back, and before closing, I cut here. I remove the previous surgical knot here, so I'm not traumatizing the papilla at all. I need saline so you can see that the papilla is perfectly healthy in the middle. And now I'm closing. I don't want to destabilize it because it's already very, very stable. But now I close with no tension. Now the last one, which is the most important of all because it's the weakest point, the area of the interincisor papilla should be always done again. So I will do it again, a bit more apical with respect to the previous one. Perforation, surgical, anatomical papilla. Take anchorage in one of the two papilla. It doesn't matter so much. We can use this time. A bit more apically than this. And now I'm closing this vicula physiologica. Now it's time to complete the closure of this last papilla. Again, trying to compress it as much as possible into the lingual side. Vai. Vai. I have to see exactly that the compression is above. And on the horizontal surface. Okay, that's the end of the story. And now the most important of all will be the next view that will show you the verticality of the vestibulum depth. Obviously in the middle we forced biology because we extended the whole papilla towards the palatal aspect. We have now to evaluate the vestibulum depth. So we have about 8 to 9 millimeters, 8 millimeters here. Look at the interincisors area where there was the frenulum. It's about 9 millimeters long, the vestibulum. And when the patient moved the lip, the marginal tissue, it's stable. There is no mobility of the marginal tissue, and the verticality is completely maintained. And the scar tissue you see, it's unfortunately the area where there was a frenulum. And this is this area that you can see. There is the previous position of the frenulum, but now we have a lot of the vestibulum depth that is completely restored. Okay, now it's time to go to the palate. You see here there's the fatty glandular tissue that we left into the palate, and this is very, very important to reduce the pain for the patient. As much as you leave into the palate, the less is the pain for our patient. We apply some collagen sponge to this area. You see that it's completely under control of the bleeding, so it's very, very easy also to stabilize mattress suture starting from distal to mesial. You turn the suture around the buccal aspect of the corresponding tooth. You fix the surgical knot apical and distal. You should try to close as much as possible the surgical knot distal and apical, because as I told you already, the blood comes from here. This is a very fatty palate, very soft palate, and so it's absolutely important to close distal and apical your suture. Second, in the premolar area, che è mezzo, hai detto?
No, è 44.
Sì.
13 e 44, sì. Abbiamo già pensato.
This is more than enough. You can also make another one, but it's really not necessary, but just to give a better stabilization to the collagen sponge in an area where the palate is very, very soft. Comunque questo però va bene, sai, dall'inizio che... Non ho tirato un nodo. This is the stability of the harvesting area. You see it's not bleeding at all. And this is more enough to give comfort to our patient.